Thanks. Okay. I want to thank the AAPLOG folks. I mean, it's wonderful to be back here, and I have to say, I know a lot of them are out on break, but one of the great things I think about coming back to this meeting is seeing the students, seeing the medical students and the college students. It really gives me lots of hope when I can see 40 or 50 of these students who are willing to come and present what they're doing for research and are so excited about life issues in perinatal care. So I can't thank them enough. They recharge me when I go back. I'm going to speak to you about the burden of abortion and the preterm birth crisis. And I give you a little bit of a roadmap here. The objectives are going to be to look at preterm birth and just really quickly review a couple of things. Some things which might be new in terms of how we tabulate preterm birth in the US. Some things have changed this year, and the numbers look different for preterm birth, and it's important that we know that. Talk about some public health issues related to preterm birth. Specifically, we're going to obviously talk about abortion, but I'm also going to talk about smoking. And I think it's important to draw a contrast between those two. The mechanisms of abortion, what might be the reason that abortion might be associated with preterm birth? Byron alluded to some of those earlier. I'm going to hit on them a little bit more as well. What is criteria for association? This is going to be generally applicable to anything you might do in medicine. It is called the Bradford-Hill criteria, and you need to know what it is, but we need to talk over it because it's important in this conversation. I'll talk about the mission or the non-mission of public health in this country, and what's being done and what's not being done. We're going to talk about counting the cost of abortion. I don't think that is the most important part of this discussion, nor should it be, but a lot of our friends where I work think it is. So we should talk about it, and let's see what the numbers really look like. And then lastly, we'll talk about what we might do next. So preterm birth, we are in a crisis mode. We have one of the highest preterm birth rates in the civilized world, for sure, in developed countries in this nation. We talk about prematurity, that's births less than 37 weeks. When we talk about the overall preterm birth rate in 2014, that number was 9.57%. So it's pretty significant when you look at developed countries in Europe. When you look at over the last 2 decades, that rate has risen about 20%. And then when you look at the numbers, it's pretty staggering to think that in 2014, we had about 63,000 births that were very preterm births. And I will refer to less than 32 weeks as very preterm births. The problem with very preterm births is they're most at risk for complications. And I've got them all listed up there. That's my world. And that's what we live with every day in the neonatal intensive care unit. And the cost of care for these preterm births is pretty extensive. I mean, if you just look at prematurity across the board, not counting relationship to abortion necessarily, we're talking somewhere in the range of 25 to 30 billion. And that's talking about old cost estimates that were done a number of years ago. Probably those estimates, if someone really got down, sat down, and was serious about it, they'd be a little bit higher. What I wanted to talk about in terms of measuring preterm birth is what CDC is going to be reporting to you starting this year for preterm birth rates. The rates, if you look at that 9.7 rate that I showed you, you'd be doing the happy dance. Because what we had for preterm birth rates in the previous year, we're sitting up somewhere sort of about 10.5%. This is what is going on at CDC in terms of how do we record what a preterm birth is. And what they had previously done is use the estimated gestational age. What they're now using is the observed estimate. So what they had previously, and you can see the different numbers here in dark blue, last menstrual period, and then the observed or estimated gestational age based on the birth provider. Typically those numbers, especially for very preterm births, are lower. So you're going to see that when I show you some data going back with data recast from 2007 through now, which is the first year that we had OE estimates, observed estimates, and that is what the CDC is now using. So that's what we're going to have going forward. So the numbers are going to look different. The numbers look better. It's not because we're doing anything differently, we're just counting differently. What has not really changed a whole heck of a lot, and this runs from right to left, so I apologize for that. 2014 is all the way on the left there, with a rate of 9.57 for overall preterm births. What hasn't changed as much, with about a 10 or 11% drop of prematurity over time in this time period, is what's gone on with the very preterm births. So we've got maybe about a 4% drop in those rates, but they're pretty consistently still combined Altogether, less than 32 weeks, sitting at around 1.6 to 1.65%. And that's a group that I'm going to focus on. So, what are the factors associated with preterm birth? We had the Institute of Medicine sit down and put together a pretty comprehensive document back in 2006. This thing is almost 700 pages long. It's a compendium of everything we know, and really not a whole heck of a lot has changed, I don't think, about what we know about preterm birth at this point. So I think in that sense, it's a great document. Here are the factors that they report as possibly associated with preterm birth. No, nobody says we have a cause for preterm birth. Nothing that we know of, anyone would reasonably sit down and say causes preterm birth. We might say that about smoking and lung cancer pretty reasonably, based on the odds ratios that we see for cigarette smoking. But no one would say this causes preterm birth. That wouldn't be actually really responsible epidemiologically. These are all associations that we know about and all of us have heard about. And I've highlighted one of the top ones up there, probably one you hear a lot about, cigarette smoking. These are what the IOM, the Institute of Medicine, called immutable risk factors, listed in a separate table, meaning that these are factors that a woman has in her history that cannot be changed, so she has got that risk for preterm birth, nothing you can do about that. We just accept that. Well, you might look at that list and say, well, what if some of these things never happen? Might that history be different? And it would be for a future person, and it might be responsible for public health care providers to think about. But in the woman sitting before you that you just enrolled in the study, yeah, immutable. But boy, you don't want her to go out and have any more of these risk factors accumulate either. And we'll talk about that too. So the IOM clearly recognized back in 2006, on page 625, table B5, that abortion is associated with preterm birth. So what happened with smoking is an interesting story, and I think it's important to look at in relation to what goes on with abortion and preterm birth. Back in 1964, the Surgeon General, based on 5 retrospective studies and 2 prospective studies, all of which were small, issued a statement, there's a picture of it down there, the cover of it, Smoking and Health, that said, effectively, that preterm birth was associated with smoking. What they defined preterm birth as, interestingly, was not a gestational age, it was weight. So for most of us, we now think of weight and gestational age as different. And preterm birth is different than very low birth weight or low birth weight. Those are sort of different animals with different predisposing factors and associations. This is what happened in 1985. We had cigarette packages and smoking products that started to be labeled with warnings related to premature birth. And that is fair enough. What had happened around that time in 1984 was a meta-analysis of those previous studies that I mentioned was released, and it showed there was a significant association. It wasn't a great meta-analysis, it wasn't great studies that they were based in the meta-analysis on, but there was some concern, and fair enough, I guess, that they put this out. What has come out since, and the only other really good meta-analysis out there looking at smoking is listed up here, and it does show, this came out in 2000, and it's from Shaw et al., shows a higher risk for preterm birth associated with smoking, and the odds ratios there are about 1.21 to 1.33. So it seems, 1.27, maybe 27% higher risk preterm birth associated with smoking. So this is what we currently know about smoking and preterm birth. It's recognized, I think, probably popularly as the most common, most prevalent risk factor that we could talk about reducing, might be arguable, but probably is, for reducing adverse pregnancy outcomes. It's talked about commonly in relation to preterm birth. We know scientifically it's more strongly associated with things like placental abruption, lower birth weight, and vascular complications related to the placenta. And this is the statement that came out of the IOM report that said the relationship of cigarette smoking and preterm birth, while it's there, is rather modest and not entirely consistent. All right? And the odds ratios for studies that show an association range from 1.1 to 2. So fair enough, this is a public health issue possibly, but that is the literature as we have it on smoking and preterm birth. So what about abortion and preterm birth? Byron said there were 148 studies, actually 149 now. So there's 149 statistically significant studies showing this association between abortion and preterm birth. 26 of these are very significant for showing the association with very preterm birth. They show also some association with very low birth weight, which probably goes more hand in hand with the gestation than anything else. There are studies which fail to show an association, but there is no meta-analysis out there that does not show this association between abortion and preterm birth. And any large study with at least 30,000 moms, or 500 deliveries, less than 33 weeks, does show this association. So systematic reviews and meta-analysis, just to really go over what that is about. It's probably in an age where we have multiple studies conducted across multiple patient populations, the gold standard that we have for trying to determine, is there really a clinical effect of some intervention or some treatment that we might institute? So the systematic review part is designed prior to undertaking a study. You go into it with the goal before the study of developing a strategy for how you're going to identify all of the studies related to this topic going back through some period of time, ideally all the way back through PubMed to the point where you started having publications. The meta-analysis part then builds on that and says we will use good, solid statistical tools to try and pool these studies together into a single quantitative estimate for effect. And that's what you've got with a systematic review meta-analysis. There are now 4 of these for abortion and its association with preterm birth. And I spoke on this last year, and we talked a little bit about the first 2 last year. These are the original ones, Swingley and Shaw. I'm not going to go a lot into detail about these studies. They were both from 2009. Swingley came out first and Shaw was second. The Lemaire study and the Saccone study. So just quickly with Swingley, this is 2009, 16 studies, almost 1 million patients in this meta-analysis. And what he showed is one induced abortion had a 1.25 adjusted odds ratio for a preterm birth, less than 37 weeks. Greater than 1.51 increased risk for a preterm birth less than 37 weeks. And greater than 1 induced abortion showed an odds ratio of 1.64, 64% increase in your chance for having a very preterm birth if you had had a prior abortion. Shaw followed this up. This was published later in the year in the British Journal of OBGYN. So he looked sort of at 2 groups, a single abortion group against a control group and a more than 1 abortion group against a control group. And you can see the numbers in the study patients up there, pretty sizable. And the odds ratio for 1 abortion, your chance for a preterm birth goes up 36%. And if it's greater than 1 abortion, 2 abortions or more, your chance for a preterm birth goes up 93%, odds ratio 1.93. So the more current meta-analyses that we now have, Lemmer's just came out, and this was in January of 2016, looks at a lot of women, 1.8 million women, and there have been a number of studies that have come out since Shaw, obviously. The odds ratio that they found for preterm birth, less than 37 weeks, was 1.29, so 29% bump. The odds ratio for very preterm birth, and this is important because we not only get an increased risk for preterm birth, but the risk for very preterm birth in association with abortion is much higher. So it seems you're much susceptible to having the preterm birth at lower gestations. And so the risk here for less than 32 weeks is 69%, 1.69 odds ratio, and then 1.68 for 28 weeks. And then what they also found is for women with multiple DNCs for preterm birth, that was a 1.74 risk. So they included in this studies, and they broke it out separately, women who had their miscarriage completed with a surgical procedure versus women who had an induced abortion. And then the last one is interesting because it's a little twist in here as well. This is, Saccone came out in December of 2015. This is 36 studies that they looked at. Again, looking at completing a spontaneous abortion with a surgical intervention, or looking at an induced termination of pregnancy. The risk of preterm birth that they got was 1.44, so about a 44% increased risk. Prior surgical induced termination of pregnancy, the risk of preterm birth was 1.52, so the prior one was all comers. They also had in their study 2 studies, well they had 3 studies, but they only included 2 of them that looked at medical termination of pregnancy. And we'll get back to this. What they found when they just broke out the medical termination of pregnancy, which I think really should be interesting to all of us to see what the truth is going to be about with medical termination of pregnancy and risk for preterm birth, was that there was really no significant difference. They had confidence intervals that were 1 to 2.25. It was a 1.5 odds ratio, but these 2 studies that they included were very small and they were very sketchy studies. One of the studies did not really, which was the bigger study, did not quantify if women, or really delineate if women had had a medical abortion completed with a surgical procedure. So that makes this really challenging data to interpret. So if you're looking at Saccone, I would kind of not really look much at the medical stuff. I mean, it gives you a whiff that maybe you want to half think, well, gee, medical termination of pregnancy and surgical termination of pregnancy, same amount of risk. We know surgical termination of pregnancy has got a higher risk. So does that mean medical has a higher risk as well? I wouldn't go there based on this data. It's not powerful enough to do that. So 2 other studies I'm going to briefly mention real quickly because they bring up critical points. The Hardy study, which is published from Canada back in 2013, and why this is important is it highlights the fact that if you have an abortion, your risk for preterm birth is higher for lower and lower and lower gestations. So the odds ratio overall was for 32 weeks 1.45, but when you get down to 28 and 26 weeks, it gets progressively more problematic. So by the time you get to 26 weeks, the risk that you're going to have a preterm birth at that gestational age goes up 217%. So a critical element in all this data. And then Clementi, they're from Finland. What they looked at is the results of multiple abortions over time. And what you can see is a dose-dependent effect. The more abortions, the higher your risk for preterm birth. And that's going to be important to remember because it goes to the issue of potentially, certainly association, but maybe even causality. So what you can see here is 1 abortion, 1.192 is 1.693 is 2.78. So, and that's less than 28 weeks. So these are fairly preterm babies. So the question comes up then, what about medical abortion? Where do we stand with all that? And we can take a quick trip through some of the data here and see what we got. This is the landmark study that everyone will point to say that medical abortion is safe and there's no risk, certainly, for preterm birth associated with medical abortion. The problem with this study, although it's published in the New England Journal and they're really quite good epidemiologists who did this study, is in the middle there. They had no control group without an abortion. So what their discovery was that the risk for preterm birth after a medical or a surgical abortion was the same. So they would assume that we all believe that there's no risk for preterm birth with a surgical abortion. They missed a great opportunity here because if they would have put in a control group, I think those of us who want to know the truth and really understand the science would have loved to have seen that. If medical abortion really is safe, we should know about that. Women should know about that. They should be informed about that. I don't want them to make that choice, but we should know. So there's a Chinese study that also tried to dig in on this as well from Lao, and this is a little bit further back, 2011. But this is in China. They had great follow-up, which happens in China, 98.9% follow-up. It was a 4-year cohort study that they conducted, and they had 3 different arms of women. It was nulliparous women that they were looking at, with 1 or more first trimester medical abortions, with surgical abortions, and then with no previous abortions. And the results, the headline, the abstract, when you read it, says this: there's no risk of preterm birth with medical abortions. Basically, end of abstract, end of story. But when you walk down through some of their data, you see that they did show, as we've seen earlier, that there's a risk with surgical abortion, really confirming what we already know. And then what they didn't talk about with their medical abortion is they had an extremely high rate of women. 20% of women required completion of their medical abortion with a surgical procedure. And when that happened, all bets were off. So when that happened, if you were less than 7 weeks with curettage going on, your odds ratio was 1.69. So your risk went up 69%. If you're looking at less than 32-week delivery, your risk for that was going up to 361%. So that was less than 7 weeks with completion with a surgical procedure after a medical abortion. That was never mentioned in the abstract. It's buried in the article. Not surprising. And then just the last study I'll talk about here in terms of reference to medical abortions is the Oliver Williams study. This was published in PLOS. It's an online journal. I think it ended up in an online journal for a couple of reasons. But it's interesting to look at for a few reasons. It's a historical cohort study of abortion in Scotland. It goes back for quite a long time, back into the 1980s. The study includes 732,000 first births greater than 24 weeks, so it's a pretty good sample size. And they were looking at preterm delivery. They did break it out for gestation. What they found overall over the time period of the study is that, yeah, there is an association overall with a previous abortion with a preterm birth. But what they broke down into epochs was what was happening. And they found it was most highly associated back in the 80s, 80 to 83. What also was going on in Scotland during this time is they started using cervical pretreatment. So when they started out, pretty much nobody was getting pretreatment. By the time they were done, 31% for surgical procedures were getting pretreatment. And then medical abortions in Scotland over this period increased from 18% to 68%. It's pretty huge. It's not exemplary or doesn't mirror what's going on in this country. And so what they produce is sort of these epochs where you can see the forest plot here looking at significance. Here's the odds ratios, here's one. If you're crossing one or hitting one, you're not significant. And you can see if you start back in 1980, you go bang, 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 through 1999, there's clearly association between abortion and preterm birth sitting out here, and here's the odds ratios. When you start hitting the 2000 period, it appears that this association drops out. The one thing that they don't have, which again, would have been really nice to have, is linked medical records. So they did not have any way to know what kind of abortion was performed, what kind of procedure was performed. So what they resorted to was just showing you, in a graph, which I didn't include, the indices for preterm birth based on women who've had an abortion over time, in conjunction with what they were doing with medical use of abortifacients. And made the assumption that since we're using more medical abortions, things are getting better, and now medical abortion is safe. And that's not really provable from what they've shown, although it's certainly an interesting hypothesis. I think the other reason it's really interesting is for what they say in the discussion, and it's right here. They speculate why their changes occurred. But what they say is the above interpretation assumes a causal association between surgical abortion without cervical pretreatment and preterm birth. And there are a number of aspects of the current analysis that support this. Causal reaction. Basically stating that surgical abortion caused the preterm births. Where have we ever heard anyone say this? This I think is just amazing to me, because now in the literature, the movement appears to be saying, well, that was the old days. We all know that there was an association in the old days with surgical abortions and preterm birth, but now we're in the new era, so don't worry about that old history. We never really covered that old history, by the way. No one has ever really admitted that. No one has ever said that, and there's decades of women who don't know that they were being put at risk for future preterm birth based on having a surgical abortion. Sorry, Professor Oliver Williams. So, is medical abortion without risk then, is the question. And I think the honest answer is we don't know for sure. Without risk in terms of preterm birth, and what the induced risk might be. And that's all I'm talking about here. Mifepristone has been approved, it's marketed, it's available. And while some people are admitting that surgical types of abortion procedures may put women at risk, they're really staking everything with medical claims of being safe on the fact that it's really got to be something about the surgical procedure that makes this problematic. So you're either potentially injuring the cervix, and maybe that's really what the problem is. And Byron alluded to some of that earlier. We'll get to that, but even if that's true, in this country, North Carolina last year, 71% of women still receive their abortions through surgical means. We are not Scotland. And even if we were Scotland, we have at least 2 generations of women who've been walking around now with the increased risk for preterm birth, and will be for probably several more decades at least, even if medical abortion had absolutely no impact on preterm birth. So what really is the potential mechanism? And I don't think anyone knows this for sure, but we sure have several potential possible causes. One is cervical trauma and injury. Going in and mechanically manipulating the cervix at the time that is done during an abortion may cause injury, may cause scarring, which makes the cervix incontinent. There may be the induction of inflammation that goes on, which is chronic, which may affect future pregnancies and really impact the ability to hold a pregnancy down the road. There may be maternal stress that results possibly from the abortion that might impact this. All the rage now when I sit in Raleigh in the legislature is that preterm birth. You know what it is, Marty? This abortion stuff, you don't want to be talking about that. What you need to be talking about is stress and racism. That's what all the abortion is, that's what all the preterm birth is due to. We are spending lots of money in Raleigh with committees and groups really trying to track down what we can do to reduce disparities because of what goes on with racism and stress. And I'm not saying that maybe that doesn't have any role, but I'm saying that abortion induces some serious stress as well. So maybe there's something going on there that we don't know about. I don't think anyone's done hormonal studies on women who are post-abortive. And then maybe there's unknown factors. But one thing to think about, and this is some basic science research that's out there, and it's on human subjects that looks at the impact of mifepristone on the cervix. Mifepristone does a bunch of things to the cervix, and they may not just be acute impacts. There's huge amounts of upregulation that goes on in a number of different proteins and enzymes. Matrix metalloproteins are released, vascular membranes are degraded, you get upregulation of a number of genes. So that sudden loss of progesterone does some things that I don't know that we fully understand. This research is that #1 reference there, and it was back in 2000 on cervical specimens from women that were undergoing abortions. And it's not been repeated. Gee, I wonder why. But, so I think we should wonder what exactly is going on when we introduce mifepristone into this environment. Are we inducing potentially some changes down the road that might put a woman at risk for preterm birth? That's totally just postulation on my part, but something I think we should be thinking about. And the last thing is that Cordium Ammunitis. There is a risk of Cordium Ammunitis after a prior abortion. So what happens with Cordium Ammunitis is chronic inflammation and infection, and there's an elevated risk for abortion after that. So this could play a role too, the chronic inflammatory pathways, which maybe we just don't know a whole heck of a lot about right now. And then gosh, you throw mifepristone in there too, on top of people who have had prior abortions. I don't know what that would do either. So I think there's a lot of potential answers and etiologies for why would this association exist. And I think that's important because what happened back in 1965, Professor Bradford Hill presented to the Royal Society of Medicine and talked about criteria that were adopted by the Surgeon General, our Surgeon General, that year when he made his statement on smoking, to try and help define what causation might be. What is association? What is causation? How do you get from an observed association to potential causation? And these are the 9 criteria that he came up with here. I'm not going to read them all to you, but they're fairly well known now. And epidemiologists in large part march to this. They aren't the be-all, end-all in relation to abortion, smoking, and preterm birth. And this is just a few of them here. Timing. All right, abortion and smoking both occur before preterm birth. Dose. More abortions, more preterm birth. Dose effect, check. Got it. Smoking, and there's a little bit of evidence that maybe if you have some more cigarettes, there might be a little bit higher risk for preterm birth, but the association is really not that strong. Consistency of effect, yes, for abortion. There are no meta-analyses, there are no big studies out there that say there's no effect of abortion on preterm birth. Can't say that about smoking. There's actually some studies that show that smoking is protective. Strength of association, pretty strong. And for a very specific group, the very preterm birth and the very preterm baby. A biologic plausibility, we just covered that. There's at least probably 4 mechanisms that you could talk about. How smoking causes preterm birth? Got me. It seems to be associated. I can make the case for low birth weight, but I'm a little bit stumped on what it does to really sort of go ahead and cause preterm birth. But this is what Professor Hill said. His criteria not the be-all, end-all, like I said. You know, they're not the sine qua non. What they can do, he says, is to help us to make up our minds on the fundamental question, is there any other way of explaining this set of facts sitting before you? The Surgeon General didn't feel there was another way to explain the abortion preterm birth link back in the 60s and then in the 80s. What do we say about abortion and preterm birth? All scientific work may be modified by advancing knowledge. That does not confer upon us a freedom to ignore the knowledge we already have or to postpone the action that it appears to demand at a given time. And then I love this quote, it's from Robert Browning. Who knows, the world may end tonight, true, but on available evidence, most of us make ready to commute on the 8:30 the next day. So, are we listening to Professor Hill? Is anybody listening to Professor Hill? Jay Iams is listening. You know, he's coming late to the party, and I've had private conversations with Jay. He's one of the noted perinatologists in maternal fetal medicine and preterm birth experts in the country. He will not come out and stand on this podium. But I know how he feels. Contrary to common belief, population-based studies have found that elective pregnancy terminations are associated with very small but real increase in the risk of subsequent preterm birth. Phil Steer, editor, British Journal, OBGYN, commenting on the Shah article that said there's actually absolutely an association between preterm birth and abortion. And you can read it for yourselves, but I think it's just amazing. A key finding is that compared to women with no history of termination, women with just one termination have an increased odds of subsequent preterm birth. This gets me. We have known for a long time, this is back in 2009, we have known for a long time that repeated terminations predispose to early delivery in a subsequent pregnancy. Whoever said that? Nobody ever said that. However, the finding that even one termination can increase the risk of preterm birth means that we should continue to search for ways of making termination less traumatic. A lot of people in this room said that, I should say. But big organizations, ACOP, even the Royal College, which has come late to the party, March of Dimes, none of these public health experts, none of these people have ever said that. And then Oliver Williams in that study from Scotland said, in conclusion, we show that previous abortion was a risk factor for a preterm birth. I mean, don't get much plainer than this. So the Royal College of OBGYN has eventually recognized the truth. This came out in 2011. This is their guideline for induced abortions and the care of women. And this is what they say, it's pretty simple. Women should be informed that there's a risk. It increases with the number of abortions. Royal College says that. I don't know where ACOP hasn't gotten the memo yet. This is what Planned Parenthood says yesterday. There are many myths about the risks of abortion. Here are the facts. Abortion does not cause breast cancer. Safe, uncomplicated abortion does not cause problems for future pregnancies, such as birth defects, premature birth, blah, 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 blah. And that still stands. That's been up there for decades. So I want to talk a little bit about abortion demographics and who's really impacted by abortion and the scourge of preterm birth that results from it. We all are. All of us as providers in this room are, but some populations much more so than others, unfortunately. So if you look at who's having abortions, and you look back to 73, this is data from Guttmacher from a variety of sources. But Guttmacher is Planned Parenthood's research arm, their publication arm, their marketing arm, their We Look academic arm. And so what you see here is abortions for non-white and for white women, starting back in 73. This is abortions per 1,000 women. And you can see the black curve is pretty high up here. And right after 1973, when we started collecting this data, it just absolutely takes off for the first 3 or 4 years after Roe v. Wade. And then in 1991, they start collecting data on other ethnic groups. So what you see over here is white non-Hispanic is right there, black non-Hispanic is there, and then Hispanic and black non-Hispanic Hispanic are caught up in the middle right here, and other non-Hispanic. So still extremely high for the black population, and actually a bit of a drop-off a little bit going on for the white population over time. And as Byron said, abortion statistics in this country, well, worldwide I guess actually, are abysmal. I mean, what gets reported to the CDC does not include California, which is probably about a quarter of the abortions in the country per year. And what is reported is very problematic. We're going through abortion data reviews in North Carolina right now, trying to understand what's being reported through separate data systems, which absolutely do not jive. And it's clear that we're probably way underreporting what's going on for abortion. So this is just a graphic looking at percent of abortions and who's got most of them. White down here, black in here, and other up here. So you can see that the majority of the abortions, the percentage, is with the white population, but the black population is only 15% or so of the births in the country. So this doesn't look too fair, I don't think. So it is clear that the folks who are using abortion services the most are the black population, and indeed, the rates are anywhere from 2.5 to 3.5 times higher, depending where you go, what states you go to for the black population. So what has been the impact of abortion on very preterm birth since Roe? And you can do some calculations, and this is based off of work that Byron and Brent Rooney and Elizabeth Shadigan did a number of years ago. And I've tried to update it, and I've updated it last year, and I've updated it again this year. And you have to make some different assumptions, because what was used as the prevalence of abortion and the risk factors for preterm birth, I'm using the meta-analyses that we have now, which Byron didn't have at the time. He was published before any of those he was way ahead of the curve on this. So the numbers are a little bit lower, and Byron's estimate of what abortion means for preterm birth in this country, and very preterm birth, is a bit higher than what I'm going to show you, but I would suggest it's still pretty darn significant. So the assumptions that you kind of have to, well, based on the meta-analyses, I'll tell you what I threw in here. The risk for preterm birth, very preterm birth after one abortion, I'm using that Swingley number. Risk for very preterm birth after 2 or more abortions, I'm using numbers from a number of folks, but including Hardy. I'm using a little less than what Guttmacher tells me, which is if one woman has had an abortion, chances are that there's probably about a 50% chance that she might have a second abortion. So I use 40%. Byron used a little bit lower number. That was about 20% actually. But I'm taking it from Guttmacher. And Guttmacher, I'm using their abortion rates for 15 and 19-year-olds. These are the women who are going to be the ones who are going to have the opportunity to have a first-time abortion and then have a child. So their rates are going to be lower than what you would see for women in their 20s, but it's probably fair, more reasonable, it's conservative to go with rates for 15 and 19-year-olds. And then looking at subgroup-specific excess preterm birth based on what we see for abortion rates. So these are the factors that I put in there for that in terms of the calculations. And then went ahead and did some calculations about what do the numbers really look like. So I broke it out, and I left on here the old date, so I apologize for that, but this is for 2014. What you can see is that the excess preterm births for whites attributable to abortion is about 13%. For blacks, it's about 20%. For Hispanics, it's lower. Hispanics, the Hispanic effect, the Mexican, whatever you want to call it, public health people call it different things. The Hispanic population has a lower abortion rate than the white or the black community right now, and then overall. And so when you look at all that and you throw it into a little calculation, a nice little Excel spreadsheet, which I won't bore you with, this is what you get going back to 1989. And so you can see here, one thing I'll call your eye to, 2007, this is where this year the CDC started using different numbers to define preterm birth. So the numbers here are lower, and we don't have that OE estimate back out through here. So really, I think if we're trying to do apples and apples, you probably are stuck just looking through here, but I put everything in because I wanted to see the larger impact of where this has been over the last 25 years or so. And what you can see here, 1989 through 2014, and total numbers every year of very preterm births attributable to abortion. The total number over the course of 25 years is 278,000. And over that time span for whites, it's 113,000. For blacks, 124,000. Hispanics, 40,000. But again, this is year over year. So every year, abortion is responsible for anywhere from, maxed out at about 12,000, down to about 8,500 to 9,000 very preterm births. So if we took all of those preterm births, we could fill Toledo. Just saying. That's how many babies that would be. The whole city of Toledo, related to abortion, very preterm birth, would be filled by the babies who are impacted by that. How about deaths? Because that's pretty high. The deaths over time are up here. Total deaths, 45,000. You can see year over year how many deaths there are for different groups. The death rate, the mortality rate for the blacks is higher. For the whites is a little bit lower when you actually do the calculations. But 45,000 over the last 23 years. And you know, just to kind of try and put it in perspective, thalidomide killed about 2,000 babies, major public health crisis back in the early 60s. 10,000 were crippled. Ebola, I mean, we talk about Ebola all the time. Worldwide deaths from Ebola since '75 is about 10,000. Korean War, we had 33,000 American casualties. So the very preterm birth deaths for babies from abortion-related preterm birth dwarf all of those numbers. We're sitting in the 40,000s. So what about costs? I really hesitate to bring this up because it's not the most important thing to me, but it is important to some of our friends who like to talk about some of this stuff. So I'm going to talk about it. So what I did in terms of calculating what all of this costs, what it means to the medical system that we're so cost conscious about, and we want to save money for, is use the TRICARE DRG calculator. TRICARE military payment system. You can go on their website. They have a beautiful little calculator. You can plug in the DRG for whatever it is you're looking at, which for these babies are 600 DRGs. You go from less than 750 grams, 751 to 999, and 1,000 to 1499, and just play with the numbers and see what you get for costs. And there's some estimation that goes into this. I'm not going to bore you with all of that, what I did. It probably could be a little bit higher or lower, or I kind of went in the middle of the road. But what I got for just TRICARE 2015 payments is $89 million. That was in hospital payments for infants that died, very preterm births associated with abortion, and $1.7 billion for hospital payments for survivors. So total hospital payments, about $1.8 billion last year. You can really bump that number a lot depending on where these babies are hospitalized because they get paid different rates. So with children's hospitals, if they were 25% of these very preterm births, and the pro fees, throw those in, you're looking at least almost $2.5 billion last year just for very preterm births related to abortion. So why is this important? So this is what some people will say. This was a response to Byron's article that he tried to get published in the British Journal of OBGYN. So this was Phil Steer, the guy whose comment previously on the Shaw article I put up, writing to one of his reviewers, because they're looking at Byron's article on the cost of abortion, and he's saying that 31.5% of very preterm births in the country are due to abortion. And they're trying to figure out, scratch their heads, how do we get rid of this thing? We don't want this albatross around our necks. And this is an email that is inadvertently sent to one of the co-authors. Email is really dangerous. By mistake. So, but what all of it is really just pretty horrific. But if you look down here, this is the attitude. The article's misleading. If they had compared the cost of preterm labor versus adoption, unwanted pregnancy, fostering versus preventing unwanted pregnancy by effective contraception, then it would have been an interesting, useful paper. So we're not that interested in what it costs for all these babies who were born for preterm birth after an abortion. We want to know what it would have cost if they lived, and we had to pay for them. That's what we want to know, if you're really interested in doing a cost analysis. So I don't know how much money, Haywood, I don't know if Haywood is still here, but I was inspired to put this slide in after he spoke this morning. I don't know how much lucre you've got to throw on the scales there till you get to the point where you say, gee, let's throw that baby out with the bathwater. But people have done it. And this is Jonathan Gruber. I don't know how many of you remember him. He was all the talk a couple of years ago. Mr. Obamacare. He was the genius behind Obamacare. And he actually conducted a study published back in 1997 that ran through 1994, looking at how much had been saved by society as a result of abortion. So what he put in sort of in his preamble or his comments up there, so they factored in a whole bunch of things. This came out of Harvard, but living in a single parent family, poverty, welfare, factored in all this stuff. So I took the Gruber benefit from abortion and put it up against the cost of very preterm birth related to abortion and preterm birth. And here's what I get. And it's all cost adjusted. So this is all in $1994 down here, right here. So back in 1994, old Jonathan said he loved what happened after abortion because we saved $14 billion. Bad news for Jonathan is that the hospital expenses in 1994 were about $37 billion. This is just the initial hospitalization for very preterm birth. This has nothing to do with the life course or the lifetime hospitalization. This is just getting out of the hospital or dying in the hospital after you're born. And then if you want to look back over time and say, gee, well, maybe it worked out over time. Maybe it was a good thing. On the scales for the green eye shades guys. Not so much. So the Gruber benefit through 2015 from 73, $45 billion. The hospital costs $75 billion. It's just a tremendous cost in terms of dollars that is being put upon our society because of this treatment. Each year, abortion costs the U.S. $740 million in very preterm birth medical expenses as compared to what goes on with the savings. So this is the actual cost every year. So in summary, it's pretty clear abortion is a problem. It takes the life of a living unborn child. I don't think we obviously can lose sight of that in any of the conversations or discussions that we're having. But in terms of where we go with this data, abortion has the potential to harm the mom in multiple ways. It clearly increases the risk for preterm birth, and it clearly does so in a more clear way and a substantiated way than smoking. Abortion is a gift that keeps on giving, unfortunately. The risk doesn't stop with the aborted child. Future pregnancies are at risk, and that's in very preterm birth, as well as the other multiple consequences in terms of mental health, breast cancer, and other things that we've spoken about. And no one talks about it. It's really pretty unspoken, outside halls like this. It's not commonly talked about in this country. So where do we go? I think medical providers, first of all, what I think a lot of us have tried to do with legislation is really have legislation that would require informed consent for women, that they would hear about this and hear about these complications and these risks. I think we've got to confront the failure of public health organizations and call them out. And it's multiple organizations. It's DHHS, it's the government, It's our public health offices within our states. I think we need to talk with these folks and try and figure a way to get through to them in the March of Dimes. I think we've got to study the relationship between medical abortion and future preterm birth, what the impact would be, what the mechanisms might be for abortion causing future preterm birth. And then the last thing I think that some of us have talked about is, depending on what the mechanism is for abortion and preterm birth, those women have an increased risk for preterm birth. Should they get 17P? That's a potential treatment that we have for folks who are at risk for preterm birth. It's never been studied. John Thorpe just wrote up a potential protocol, see if the state's interested in looking at this. But I think someone has got to do this. And the bottom line is, if abortions were bananas, and they ain't, and we had all the evidence that we've got, this is what you would have on abortions. So thanks.